Tuning in. Good evening. Appreciate everybody tuning in tonight for the second in a series of webinars and really roundtable discussion that sponsored by the Aesthetic Authority. We very much appreciate them allowing us to put together this discussion panel. Really, the discussion tonight is a little different than the previous discussion, which was what we were doing while we were not seeing patients and while we had downtime. Tonight, we're in a very fortunate position that we can now talk about the light at the end of the tunnel. We can talk about opening our practice, which is very exciting for all of us. I think we've seen enough of our homes. We've done enough of behind-the-scene preparation, and we're all anxious to get out there and see our patients again, interact with our patients, which I think we all have really missed. And that's the thing that probably I've missed, is interacting with my staff on a daily basis. And interacting with my patients. So fortunately, there's light at the end of the tunnel. This evening, we have really just an all-star panel. I'm going to start by introducing the panel to you. Susan Winkle, who really needs no introduction in the dermatologic world. Susan's in Bradenton, Florida, and she is an outstanding physician, but also an excellent manager of a practice. And I've had interaction with Susan for many years, and it's just great to have her on this panel. I think the next person up is Mara Shore. Mara is in partnership with her dad, Jay Shore, Shore Solutions, and so Mara is an outstanding Ivan Wayne is a outstanding facial plastic surgeon. He has a really innovative Facebook discussion site that I participate in, the Aesthetic Practice Think Tank. It's really well thought out. Anybody interested in joining that discussion group, we can always use some new faces and new voices. The next person to introduce is Dr. Jason Posner. He was part of our last discussion group. It's really great to get his input in Boca Raton. Never know how many people are in his practice or who they are, but he always runs a multi-specialty practice, is a very busy plastic surgeon, and we'll have some interesting input as always. Dr. Ed Williams, outstanding facial plastic surgeon, who is from Albany, New York. Ed's been the president of the American Academy of Facial Plastic Surgery. He's been a lifelong friend, or a longtime friend of mine. Not lifelong, but longtime friend, and really great to have Ed on this particular panel. Next person on your screen, Morgan, and Morgan Curry, who is one of my nurses, and I wanted to bring her on to provide some staff input because the staff is going to be key in helping us get our practices open. Our staffs couldn't be more important to us. They're always important, but they couldn't be more important to us than they are right now. There's some hurdles to jump over. There might even be some landmines out there, and that's why we have Alex Tirish, who's a landmine expert. Alex is an attorney. He's been part of many of my programs at both Vegas Cosmetic Surgery and Global Aesthetics. It's just an outstanding attorney who's not only the executive director of the American Spa Association, but also has a very active private practice with a number of colleagues who I've gotten to meet over the years. And it's always interesting listening to Alex. So with all that having been said, those introductions, let's get started. I think the first thing that we want to talk about, and we'll start with, I'm going to start with Mara, and that's to talk about appropriate ways of letting our patients and the public in general know about know that we're opening our office and give them a certain comfort level that we're there, that when they come to our office, that they're in good hands and that we're doing things the right way.
Absolutely. I think that is so key. Really conveying the safety measures. The entire nation has just been through, the entire world has just been through something really, really horrific, and we're not yet completely over that hump. So knowing that the way that we market and the way we communicate with patients is going to be really, really different than how we used to. And at least for the time being, it's not just a matter of tossing up some before and after photos. Even if they're great before and after photos, it's not just a matter of tossing up before and after photos and ignoring the fact that we've all just been through this together. So we always say that you really need to be sympathetic to what's going on, convey those safety measures. And there's a lot of things that, as a practice, you probably did differently and should have done differently over the past 6 or so weeks. And so there's really a whole checklist of things you need to make sure that you're still addressing in all of your marketing. So I would say, put any sort of pop-up message that you previously had. You want to make sure that you turn that off and let patients know that you are back in business, and let them know what are you doing differently. So how is scheduling changed? Make sure that every team member has scripts as well. And as far as how can they answer the frequently asked questions that they're going to get about the practice reopen. Make sure that you are updating your listing services as well. So if you had changed your hours on your website during COVID, if you had changed your hours on your social media channels, which you should have done, make sure that you're switching them back and you're updating them at this point. I would say communicate with your website companies and let them know that you're opening back up, because they all have really great checklists of what it is that every single one of their clients is getting ready to do. And so really messaging and acknowledging what your patients have just been through, as well as where we are going through this together, is going to be incredibly key. So there's just so many different things that we're going to be doing differently.
Those are excellent considerations. But I do want to mention before that we are taking questions, and we will probably spend the second half of this this discussion fielding questions for our panel of experts. So we will have plenty of time for questions. Ivan Wayne, Dr. Wayne, I know that I think you've already been open in Oklahoma City, maybe one of along with Georgia.
I'm sorry, you cut out there. I missed your question.
Yeah, Ivan, I'm sorry. I know that in Oklahoma City, I think that you guys have already been allowed to open this week, and the state of Oklahoma has been kind of ahead of the curve on some of this stuff. Can you tell us any challenges that you've seen so far in opening your practice, and maybe what you think the two biggest hurdles have been?
Well, we actually have been open continuously since the state shut down, which happened about 5 weeks ago. Because I treat Mohs cancer patients, that's considered essential. So we've been slowly operating the whole time, which forced us to come up with an early plan. And what we've done is make the waiting room basically a pass-through zone. We don't have people congregating. We see one patient at a time. They stop outside, they call in, we bring them straight to the room. The target has been a moving target the whole time, because it started out with no testing available. We just brought people to surgery, did a good history, everybody wearing some pretty sophisticated protective gear in the operating room, to now we have testing available, and we're trying to figure out how best to add that into our practice. And what we're planning to do, we're opening up on Monday to cosmetic patients. I have a 5-week backlog of patients that we're going to be accommodating somehow. Is we're going to shoot a little video from the patient perspective on what the process is going to be like. I think there's a lot of fear out there. I mean, I'm afraid to go to the supermarket and to go to Home Depot. I mean, there's people around. A lot of people aren't wearing masks. I don't know what's going on with them. So I want to make sure the patients feel really comfortable when they come to our office and see all the measures that we're taking. We'll post it on our social media, on the website, but it's a process we've been evolving to the point now where I think we have it figured out.
Very good. I think we're doing a lot of those same things. It's interesting when you mentioned the video, because I do some video today. We have somebody that does videos on our staff and really good at it. And, you know, all four doctors in our group participated in segments of that video. Dr. Posner, I know that you've been, are you just opening back up, or no, you told me, I think on the phone, May 11th is your opening date. Have you got your staff working on preparations? And if so, what are the 2 or 3 things that you think are going to be the most important things in getting really ready to reopen your doors?
So Randy, we've been open continuously since this started, but just seeing post-ops and mainly virtual consults. But we haven't operated since March 20th, and we hope to be back on May 11th. We're not sure yet, but we hope. It was interesting being on this call today because I spent the morning going over protocols with my managers. And we sat down and we wrote out a protocol, and I think everyone needs to do that. Probably you can borrow someone else's and see what they've done and adapt to it, such as, how many people in your waiting room? Are you going to take temperatures? Are you going to see how many patients at a time? Whatever your templates are that you normally see, are you going to change those templates for the patient days? And on the surgical days, are any preoperative testing, postoperative testing? I mean, what are you going to do differently? So we're working through that. I mean, obviously everyone has to wear a mask and glasses and gloves and, just I think specific protocols for the office. I don't want anyone walking around outside in scrubs. You need to come in your street clothes and change in scrubs in the office. I don't want them wearing my sanctuary plastic surgery scrubs in Home Depot or the supermarket. I think that looks bad for us. I think that everyone needs to kind of really sit down and come up with some logical things with solution-oriented. We have to be solution-oriented and not just say, well, there's a problem, and what do you suggest? Well, I don't know. We need solutions, and I think we can work through this together. I keep talking since Randy's frozen. Yeah, Randy's connection speed is off. So anyone else want to take the same question? I mean, we can talk about preoperative testing. So I'll kind of change this out until Randy gets his feedback. The question is not what we're going to do in our med spa, because the med spa is sort of similar to our patient days. Patient comes in for Botox and fillers. We'll check their temperature. Everyone's got to be in a mask. The staff has to be okay with coming into work. If they're not, they need to stay home. We have one staff member with a very sick husband, cancer patient. So she's probably not going to be coming back to work so fast. But the real kicker is the surgery side. I mean, I'd like to hear what you other guys have to say about preoperative testing. I mean, we actually tested everyone in the office yesterday for antigen testing. We actually turned up all negative. But I want to know what to do with antibody testing. I want to know about antigen testing. So do we need to test the patients preoperatively? I wish we had a fast test. Can they window? What kind of paperwork do we need from a legal perspective? Is it like a pregnancy test where you need to sign off that you may be in a window period between testing and a positive result? So I think these are the questions that we're all asking at the same time as to, what type of preoperative testing do we need for the surgery patients, especially if I'm going to stick a tube down their throat on the general anesthesia case. So anybody else want to take that while Randy's frozen? Edwin?
I can take. I mean, this is the thing we're struggling with too, right, Jason? I mean, there are guidelines, American College of Surgeons, ASAPs. Yes, it has all kinds of guidelines out there for bringing patients in your practice. We're doing the same thing, just opening what we call our med spa and doing the surgery. And so the testing is what we're concerned about. We do have, and I'd be happy to share with people the forms that we have, the protocols to follow for our staff and for patients that are communicated with. At some point, we're going to see good, reliable, fast, inexpensive tests. But as everyone knows, the FDA has not signed off on any of the testing yet, whether it's serology testing, IgM, IgG, or the active COVID to make them, readily available to all of us. It's our intention to screen everybody first. They get a call a couple of weeks ahead. They have to be quarantined, all that other stuff, and then I plan on testing people for serology and the active COVID. Where I will tell you, we've looked at a lot of labs out there, and you have to be careful because there was one lab that we had. It was for the serology test. It was Abbott with one T, And all of a sudden today they're gone. They're not on the internet. They're not answering their phone. So there's a lot of charlatans out there. And I think this is what concerns us. And even with the active test, it's only 60%, right? There's a 30% false, I think, negative. So I just look at belt and suspenders, anything we can possibly do. But if we're going to be, especially with nasal cases, if we're going to be operating on people, I think at least if we do all of the screening, we do all of the testing that we possibly can, to me, that's what scares me, the operating room, and then things like fillers and that sort of thing. I don't know if there's anything more I can add to that, but.
Let me go back. I'm sorry about the interruption. I don't know what it's interesting on the technology, but we talked about announcements. Now we've got to bring our staff back, Ed Williams, and I know that some of us have furloughed staff and others have kept staff on board. What are you doing in terms of your staffing before you get open and now? And what will you do if somebody says, I think I'd rather remain on unemployment for a while, but I'll be back in a couple of months? Or perhaps somebody that says, I'm really afraid of this virus and I'd like to kind of stay and shelter in place for another couple of months. Your reaction?
Yeah, that's so we had people, well, we kept furlough and kept on kind of management team, our CFO, our marketing, sales, and really use that time to work on development, like strategic, some of the things that we don't get to, some of the projects we don't get to. We just, we had one or two nurses, really one full-time nurse to take care of the skin cancer patients that my one associate takes care of. We just this week started bringing people back, patient care coordinators, more nursing staff. And we haven't had, we're prepared to deal with this. We haven't had anyone yet say that, I would rather stay home. I think we'll try to work with them. I did have this conversation with our operations person, Susan, because the other day we were talking about, who would do better and staying home, and unemployment and that type of thing. And I said, look, this isn't really a negotiation. We're all fortunate that we can come back to work. But we do want to try to work with people. Fortunately, we haven't really run into that yet, but I think that's a really important question. We did have one of our nurse injectors who's, she's mid-60s plus. Her husband is the same, and she's concerned. So we're going to maybe have her working by herself. But I don't know if someone says I don't want to come back. I believe if you've offered them a job and they decide to stay out, I believe that I don't know if their unemployment runs out, how that works. Maybe
Alex
I didn't
Tiersch,
answer
that like something. Yeah. No, you did. Alex Tiersch, from a legal point of view, what issues do we have to consider with employees coming back to work? And, are there any landmines there that we need to consider? Your thoughts?
Yeah, there's lots of landmines. And the good news is that we know they're going to be there. The bad news is that we really have no idea where they are, because this is totally new territory for all of us, including attorneys. I know we're dealing with this as much as everybody else is. So it's not an easy question to answer. It really depends. So when employees start coming back, obviously you have to be cognizant of what the local regulations are, the state regulations, and whatever the orders have come down from both, the governor, local, and then even the medical board. You have to be aware of what those are. But at the same time, there's a major PR component to this that you have to be aware of, in that, there are going to be COVID-19 related employment actions that come out of this, 100% guaranteed. We don't know exactly what they're going to say, but I think the idea that forcing somebody to come back to work when they're uncomfortable with it is a difficult thing to have to justify in the PR sense, even if you have a legal leg to stand on. I think it's going to depend a lot on what the actual order is. If there's different levels of whether it's a shelter in place, whether it's an elective, if you're in a state that allows elective surgeries. There's not an easy answer to that. One thing that you can do is have everybody, including patients, including employees, like in a handbook, kind of acknowledge that there is a certain risk under the circumstances, and that you're going to do everything that you can to protect them. But from an employee perspective, especially in a state like California or Illinois, where I am, where the employees are protected a lot, you really do have to be very mindful. I don't have a good answer for that. If you're in a state like California and there's an employee who does not want to come back, you're going to have to engage in some negotiation and get to a point where they feel comfortable being able to come back through protective measures, distancing, things like that. Otherwise, I can only imagine the liability that comes with bringing them back, making them feel comfortable, and then they get sick or they get somebody else sick. It's a big mess. I would very much. This is where the employment attorneys in the world are really cutting their teeth and making a lot of decisions. So I would make sure that you consult with a local employment attorney who knows the rules in your particular state.
Morgan, speaking of employees, Morgan, I know over the last week I've probably burned up Morgan's ear talking about protocols and getting us ready. I didn't even know it was going to be as complex as it is, because there are a number of hurdles. Morgan, how just in speaking to the nurses out there, how stressful is this for people working in a practice? And let me make one more point. I think everybody out there ought to consider, just like we have OSHA directors or OSHA overseers in our practice, we appointed Morgan as our COVID director. And I think every practice ought to consider having one person kind of head up and look at all the different regulations coming down, because I've seen guidelines from ASPS, from ASAPS, from the College of Surgeons, from the state of Kentucky, which is most important to us right now, from the CDC, for sure. We've seen that from the very start, and the federal government. So we've seen a number of different guidelines come down. Most of them have a lot of things in common. But Morgan, can you address all the different things that we've talked about maybe over the last 2 weeks in order to try to get our practice ready, and maybe how stressful that's been?
Well, it's definitely been stressful for me because we're working on a skeleton crew. So Dr. Waldman's been working remote from home, and you have other doctors that you're trying to communicate with and other staff that aren't there. So it's been a lot of virtual communication. And then trying to navigate through all of the different credible sources. Like Dr. Waldman mentioned, there's so many, and they all have a lot in common. So it's really picking through that and determining what works best for you all as a practice. I know that there's a lot of different types of practices that are tuning in tonight. Our practice has a little bit of everything. Facial plastic, body plastic, skincare, med spa, etc. And there's a lot of different facets that play a part in that. One of the other doctors already talked about. What are a couple of the biggest challenges you've faced so far, you think, that everybody's probably going to have some sort of testing? That's already been, it's already been hit on. Allocating the laboratory that's going to read them, and the turnaround time, and the, how accurate they are. And so that's the first one. And getting this backlog. We have 6+ weeks of backlog surgeries between 4 physicians, and everybody chomping at the bit to get in. Everybody's off of work. So everybody wants that first surgery spot. And it's a matter of slowing down and determining, okay, well, what do we do first? What cases do we start with first? Do we put the first person on, or do we start with the the quicker cases that less anesthesia, that have less, negative outcomes with surgery, that we can knock out quicker. So that's been a challenge as well.
And also supply chain has been a major challenge.
Supply chain with anesthesia. I mean, we have our own OR, so in our facility, and luckily we pre-ordered a lot of our drugs prior to the shutdown. So we're having to potentially think about rationing that and how we go about scheduling that, because a lot of, things like propofol are on back order. Things like PPE and N95s are on back order. So that, that's a struggle as well.
So in Kentucky, just to clarify, we have to use N95s. We have to use testing. It's not an option. It's something that they've mandated, that we have to test our patients before we do surgery. And so the challenge is when do you test them, and how reliable is the testing, and can you really count on it? And today, and I'll call on somebody in a second, but today, anecdotally, I know that in New York, that out of 300 people they tested at a hospital, that only 11 tests came back positive for IgG. Now, that defies the mind, because we know that a lot more people have been infected. So when is the IgG turning positive? If you look at the fine print, it's 6 to 8 weeks, I think. And then if you also look at testing in general, there's at least a 30 or 40% false negative rate. So let me go back to Ivan Wayne on that. Ivan, you mentioned something. How trustworthy are these tests, and can we really can we really rely on them? And as surgeons, when we walk in, just because somebody's had a negative test or a negative IgG, or positive IgG, I guess I should say, can we, hang our hat on that? Tell me your thoughts on that.
Well, I've been operating all along, and we started with no tests available to the hospital that I work at, testing everybody. And our thoughts are, after a careful analysis, that 2 tests about 3 days apart and a 2-week self-quarantine was high reliability. But as we know, there's a high false negative rate. The number is between 40 to 20%, depends on what source and what test you're talking about. That's what the swab PCR test. And the antibody test, nobody really knows what it all means. IgG is probably good. We don't know if that means you're immune. What level, I think we'll know a lot more about this as we progress into the summer. But I don't think we don't have a choice in Oklahoma. We have to test everybody to operate on them. So we are doing it. And I've decided that if the patient can't wear a mask and I'm doing a procedure, I'm going to test them. And so far, all the patients have been very receptive. In fact, they seem relieved to know that they're going to get a test, because they're thinking, well, everybody else in the office is getting a test, so it's a safer place. I mean, we're promoting it that way. But I still assume, just like, with any infectious disease, assume everybody's infectious and treat them accordingly. And that means universal precautions and what level is appropriate, N95 or an air supplied respirator in the operating room. I'm planning to use N95 or higher once I start doing injectables, because I don't think you can take a chance. And eye protection, and everybody that's near the patient needs to assume that they're infectious, even with a negative test. I think if you don't get a test and there's something bad happens, you're going to be called to question, why didn't you get the test? Even if they're not good, they're not perfect. I think because they're available and we're doing elective cosmetic procedures, I feel we have to test.
Susan Winkle, Dr. Winkle, from a dermatologic point of view, or from an injection point of view, how are you going to approach doing injectable fillers, particularly around the eyes and around the mouth? What are your thoughts about that? That seems to be the area maybe of the less invasive procedures for the greatest risk.
Yeah, I definitely agree that that's clearly, for us personally, a very big risk. So what I'm doing is, first of all, we plan to start next week with a very slow start. Because first of all, we're all out of the rhythm, my whole office staff. And we have to make, first and foremost, as everyone has alluded to, my staff has to feel safe. So I've ordered every mask possible. We have N95 masks for everybody. We have KN95 masks, which quite frankly are more comfortable than an N95 mask. And I've ordered TheraMask, which is another mask that's incorporated with copper. If a bacteria or virus lands on that, the literature shows that it will kill the virus or the bacteria in that TheraMask. And so I'm giving all my assistants, all my employees in the whole office, 3 choices. They're going to have a variety of masks. And so, because who can wear that same mask sometimes all day long? They get very uncomfortable. So first and foremost, I got to keep my staff feeling comfortable and safe. And just like Ivan said, we're going to assume every patient is positive, just like we did back in the old HIV beginning days. If I'm going to operate or touch a patient or inject a patient, I'm going to assume they're positive. So I'm going to start out with only doing procedures while they can keep their mask on, just till everybody gets comfortable with the flow. Then I, along with my employees, if someone's in there with me, is going to have on the most protective mask that we can get. And we're going to wipe down the room before the patient comes in. We're going to have my employee protected. We're going to wipe them down with Technicare before I inject them. And I'm going to try to stand at the side as possible of the bedside, how I'm going to position myself. I'm going to keep my employees away as much as possible from direct contact with those patients. So we've really thought through with my staff kind of overall how we want to protect ourselves and how we're going to protect the patients and address them. One thing I'll just let you know we did, because I've been in practice for almost 40 years, and I've never had a marketing budget. I'm a solo private practitioner with a nurse practitioner who's been with me for 30 years. And during this time, we decided to actually work at developing an email list. And this week, we've sent out a very personal kind of email to the patients. I think we sent it to about 10,000 patients, reassuring them that we're protecting the office. We've rearranged the reception area. So we've taken a tape measure and measured 6 feet distancing. We're going to tell the patients in this letter, we told them, please leave that person who comes with you out in the car if possible. Don't bring anyone else in. If you're uncomfortable, we'll text you when it's time for you to come back into the room. So we really, as you've all talked about, kind of developed a structured protocol that patients and staff all need to do, that we're going to do to try to make everyone feel safe and provide quality care.
Those are all excellent points. It's a great, a great description of what you're doing in your practice. Dr. Williams, are you going to see as many patients, and if not, how are you going to regulate the flow of patients in your office, and what's going to change in terms? Susan already mentioned social separation. Actually, in Kentucky, the guidance is really no one in reception areas. And I'll tell you a little bit about what we're doing, or I'll let Morgan do that. But Ed, how is the flow for the next month or two going to change in your practice, and how is your scheduling going to adapt to that flow? Your actual scheduling, both primarily patient-wise in the clinic.
So first, again, we start by screening the patients, and through Patient Now, which the software we use, and I guess it's Constant Contact, we are able to text the patients when they can come in. So we will be texting them when they come in, and we have plenty of room in the reception area, but I don't really see anybody sitting in there. I would imagine it's going to be at about half of the flow. I mean, and what we initially planned on with the injectors is to have one injector at a time. We met with them today, and they're happy to have 2 there, but we really are cutting down the flow. I think Susan made a really good point. We've been out of rhythm, for a while too. So we're opening up next week. We brought our staff back, but we're really starting with patients next week. But it's going to take a while. We even did the same thing with when we look at opening our surgery schedule for around the 15th, which is a Friday. But we're going to start back. We have some of the my partner who does skin cancer. We're going to weave in some of the cosmetic patients, a much slower flow in the operating room until we get the moves down, because these things are all going to take a lot more time. I don't know if that answers your question, Randy, but
it does. It does very well. Very well. Morgan, tell us.
I think part of it is getting comfortable, right? I mean,
yeah. Morgan, tell us a little bit about some of the protocols that we're doing just from the time that a patient, comes to the office, enters the parking lot. Just talking about in the clinic for either consults or follow-ups or even injectable patients. What are we doing differently in our practice?
Sure. Well, first of all, we're going to start slow rolling everything. So we're really pushing the telemedicine, the consults at first. But when we do ramp back up to injectables and seeing more patients in the practice, we do have a very well thought out protocol. So it's going to start by texting the patient, or the patient's going to text us when they arrive. And all of this is going to be communicated to the patient the day prior to surgery. So this isn't foreign to them. So they're kind of aware of the new flow. They're going to text upon arrival. A nurse is going to meet them. We haven't totally decided, either at their car in our downstairs lobby. Our office is on the 3rd floor. And they're going to have a temperature check, and they're going to have a pre-screening questionnaire that's emailed to them. Hopefully they will do their part, fill it out. If not, they'll have to fill it out there. And the nurse will evaluate that. If all is good, they'll be sent up on the elevator, one person at a time. Nobody is to accompany them unless there is a physical mobility issue. No children in the office accompanying the patients. Another nurse will greet them at the elevator and escort them to their sanitized room, and then all doors shut during procedures. And, everyone obviously is to wear a mask. The patient is to wear a mask. The providers, the other staff are to wear masks. Even the girls answering the phones, the patient coordinators. We're going to try to minimize contact at all times possible. So payment is going to be taken over the phone as much as possible. Follow-ups, same thing.
Very good. Dr. Posner, is there anything there that we've left out that you're doing down in Boca?
The funny thing is that independently, everyone's came up with the same solutions. We've done the same thing. I mean, one thing that hasn't been mentioned is no family members are going to be waiting for any surgical patient in our waiting room. Normally, there's someone waiting while someone's in surgery. That's not going to happen. I don't think the surgery days are going to change that much. I mean, it's a surgery day. It's a low flow state. You do a couple of cases that day. They're well timed between cases. That's not going to change. But as everyone said, everyone came to the same conclusions. There's going to be a big slowdown on your clinic days and on your injectable days. And we just have to make amends to that. Just everyone said exactly what we're doing, independently came up with the same solutions. No children. You can't come up with anyone else unless you have a disability. We're going to bring you up from your cars, or we're going to text you when it's time to come in. No one's really going to be waiting in the waiting room. Everyone's got masks on. I mean, we've all really came up with the same things. And as I said earlier, I just don't want anyone walking around outside with scrubs on. One thing we said is you need to come in your street clothes, change into scrubs in the office, and change back. I don't want contaminated scrubs in Publix or Home Depot before or after the office. It looks bad for us. And one of my staff.
So what about testing, Jason? What are you guys doing with?
So, and the only thing is we haven't quite figured out what we'd like to do yet. We're waiting for some guidance. We're probably going to be testing the patients preoperatively. The question is that same window of what happens if you get exposed and you're in that negative zone. We don't know yet. I mean, I wish there was a rapid test that we would test them a couple of days before and then that same day in the office. That would be great. But probably we're going to have to do some testing a couple of days before. We're waiting for some guidance. We may be mandated by the state, which we haven't yet. But, I wish we, as I said earlier, we all got IgG tested yesterday. We're all negative. I wish I was positive. I wouldn't have to worry so much.
We have one of our doctors that actually is positive. I'm really envious of him because he really didn't suffer much to get that. So Alex Tirsch, you've listened to what we're doing so far. Are we doing anything wrong? Is there anything more that we should do in your mind at this point? And I'll get into consents in a minute, so I'm not going to talk about surgery yet. But so far, what you've heard with the plans that we have, are we missing anything?
I don't think so. I think what's been discussed has been spot on. It's been really insightful, and it's interesting that you're all coming up with the same ideas. There's so many resources out there, the different colleges, the different associations, they've all got it. I think the important thing is to think through the protocols in a realistic way. Something that I think Morgan touched on that I thought was really a good point is that you have to kind of enact it as if it's happening. And then, so you have to think through what the actual process is going to be. It can't just be a theoretical exercise. You really got to figure out what it's going to be. Then have those protocols put down in writing, make sure that everyone is familiar with them, and then really, really practice them. There's one of the things that we as lawyers always get a little upset by is when someone will say, here's my protocol for whatever it is. But then you go and talk to the staff and nobody ever follows the protocol. It's just up there gathering dust. It's form and substance have to be the same. You have to have the protocol and then everybody has to follow them every single time. Be militant about that. Make sure that everyone is educated on them. And I think the education of the patients is a huge key too. The more that you can let them know what you're doing, the more comfortable they can feel. Obviously, there are going to be consents that we'll talk about that you want to get as well. But no, I think there's no silver bullet here. There's no right answer. It's you have to figure it out yourself. I think the testing is a big issue. I wish we would have quicker testing because that would make a lot of our problems a lot easier.
Yeah, Morgan and I spent a long time talking about protocols today. By the way, I just got a text from the people at the Aesthetic Authority, and Eliza Cabana is the editor. They do have some nice protocols that are already posted on the Aesthetic Authority website for the entire audience to view. I think the first publication from the Aesthetic Authority should be coming out in the next couple of weeks, hopefully. And so that's, for those of you that don't know, the Aesthetic Authority is a sister publication to both Dermatology Times and Medical Economics, owned by the same people. And it's a new publication. I'm honored to be the medical editor, but it's got a lot of people contributing and working with it, and so hopefully it's a valuable. It's actually, they're telling me it's out now, that the digital issue is on the site. The printed issue hasn't gone out in the mail yet. So thank you for that reminder. Get these little texts in my ear. So. So, we're talking about the one thing that, we're still going to try to do in our practice is we're still going to try to do as much, as Morgan mentioned, as much virtual consultation as we can. We're actually finding probably, maybe even a better conversion rate, that magical word conversion with virtual consultation. So I'm going to go to Mara Shore. Mara, you've heard how, a lot of us have come to the same place with this. But, what are two things? What are the best ways to let our patients know that we're really advocating for them and that we're following guidelines? And if they come to our office, it's a very safe place to be. And number two, your thoughts on virtual consultation and what I just said about maybe that we found something that perhaps will stick around longer than even the COVID, virus.
Sure. So I think that there was a two-part question in there. So with, as we look at letting patients know that everything is safe, it's really all, I know we've said again and again and again, it's protocols and it's scripting. I think that leaving your staff, letting them go unscripted, it's hard enough for all of us to know on a daily basis how laws are changing, how protocols are changing, what's safe one day is deemed to not be safe the next day. And so it's making sure that you have a current script available for every single member of your team as it relates to safety as it relates to bullet points for what your practice is doing, and not just letting them go off the cuff. So I think giving them actual bullet points, giving them script. It sounds like, Morgan, that's what you guys, in the practice spend a lot of time doing as well. And so I think that's one really important component, making sure your staff is picking up the phone before surgery, before they actually schedule that appointment. So when they're actually connecting with them and having all that information right there. When we talk about virtual consultations now, we have seen practices, we work with practices across the country. And so both surgical and non-surgical. And one thing I also encourage you is to really pay close attention to what is allowed in your particular state, because just as what we're all talking about, what's allowed in Oklahoma is not the same thing as Kentucky or Texas or Florida or California. And we touched on this, but it's different as far as employment law. It's different as far as utilization of certain purchases of PPE, et cetera. But when we look at virtual consultations, promoting virtual consultations, and long after the shutdowns and the shelter in place is lifted, seeing really strong success with virtual consultations and letting that continue to be a viable part of your practice. It's going to save everybody time. It's going to save everybody money, but making sure that you treat them like they're actual consults, and that you look at how are you creating patient charts, how are you utilizing consents, et cetera, and making sure that all those things are in place, because what you don't want is that you just treat it like a FaceTime call. And you want to make sure that the virtual consults are HIPAA compliant, that everything is charted, that you have everything in place, because if it doesn't end up there, then it didn't happen. So I think making sure that you really have that option.
Thank you. Ivan Wayne, is it necessary to have people using, let's say, following items when we do injectable procedures or something up close to the patient? And we'll start with the concept of eye protection or visors for patients. Are eyeglasses alone okay, or do you recommend that we all have visors for our entire staff to cover their entire face, as well as a mask underneath that visor?
So I think it's a good idea to have more than just glasses. You need a face shield of some kind. I'm talking about for a procedure, either an injectable, not just Botox, but an injectable filler around the mouth, or minor surgery, or operating room. So that means either the shield or the mask with the shield, or some you can get these goggles that almost have a seal around the eye with a little foam cushion. When I'm operating, I'm using a full air supplied hood with a shield, so all my nose, eyes, mouth are completely protected. That's the only thing I feel comfortable.
Can you show us? Didn't we
yes,
left it in the office? Did you?
Yes.
Yeah. Well, we wanted to see Ivan's full gear, because I've seen that, and I'm like, oh my gosh. But there's how it goes to the operating room.
This is what you wear around your waist. There's a little motor that blows air through a filter here. And then the part you wear on your head looks like this. So it looks crazy. It's a little intimidating for patients, but they're asleep. It's very comfortable, I have to say. It's cool. It's compared to an N95 mask. I've been operating up to 10 hours a day using that, and it's been perfectly fine. I'm not ready to start using that in the office with injectables. I'm not sure patients are going to be cool with that. I'm using these little silicone half mask respirators, I think. And I have what those look like. So this is the actual face piece. And then there are different filters that you attach. This is made of silicone, extremely comfortable. And there's very little resistance to breathing. So that's what I bought enough for all the staff that are going to be with me doing injectables. That's what I plan to use. you can get N95 or N100 filters. They're hard to find, but I've managed to get them through eBay and Amazon and kind of piecemealing it.
Well,
and then
Susan Winkle, are you gonna be using that kind of equipment when you inject your patients? And tell us how you're going to protect yourself and your staff. Are you going to have bunny suits, scrubs that you change into, a special type of mask, a special type of eye protection, or none of that?
Well, first, I'd like to reiterate, I think there are some really good points brought up tonight. Number one, I don't want my scrubs at Home Depot. Everybody in my office wears scrubs, and I think that's a really, really important point, Jason, that we can't have people leaving our office and when they open things up, going to Home Depot and out and about. Because it's just the wrong image. Even in my because I'm a Mohs surgeon in the morning and I do my cosmetic things in the afternoon, and I really think that image is very, very important right now. Ivan, in all due respect, I can't see me wearing that, but I do think I've got to wear a mask. I think that the plastic shield, even though I'm wearing my glasses these days, I think that plastic shield with my mask underneath is important, especially when I'm doing surgery. Because Lord knows I get blood all over me, just doing my Mohs surgery. And I think that my assistant and I both have to have those shields on and the mask underneath, because the shield alone obviously is not going to protect things from aerosolizing going up. I think this TheraMask, I haven't received them yet, but the one I mentioned that's impregnated with the copper is going to be more comfortable maybe to wear all day. Unless I'm going to do something that I think if I have to operate on someone's mouth, I have to do a big flap on the nose, I think then I have to wear something that the FDA has vetted and says is protective. I did do some research today, and it's quite interesting. If you go on the CDC site and look to see what the CDC recommendations are for all the things we're discussing, not there. The CDC is really not up to speed on and I realize it varies from state to state, but nonetheless, we're all talking about some very common guidelines that I think are essential for every one of us.
Is anybody on the panel mandating like bunny suits over our scrubs? I'm just curious. One little item. Anybody mandating that? Because that's something we've discussed. But so let's go to the next subject, and that's really surgery. But I want to interpose one quick question to anybody on the panel. We've been thinking about even just things like janitorial services. Like we have, a janitorial service come in every day to do cleaning. And now we're starting to think, well, we've got to probably think about testing them, and we've probably got to think about setting some protocols and standards for how they dress and what they put on. Let me go back to Dr. Posner. What about, I know that you probably have the same thing going on that we do with an evening janitorial service cleaning up maybe both your OR and your clinical region area.
They're here now. I'm in the office. They're here now. I have my door closed, but they're here now cleaning up. But, I think, listen, I'm listening to a lot of this stuff, but, I operate on HIV positive patients and hepatitis patients. So, pretty regularly, we take universal precautions. We wipe down the room every day between patients anyway. So, we're already doing a lot of these things that people are talking about. So, we're going to clean up maybe a little bit more. One thing is we shut down the coffee and water service because we don't want anyone touching that right now in both our spa and our surgery side. But we're going to have someone every hour wipe down the stuff. We just cleaning up a little bit more. But our office is spotless and always spotless. There's not a speck of dust anywhere.
All right, Jason, on your spa issue though. Special challenges in the spa right now: microneedling, hydrofacials, any of the dermaplaning, any of those types of procedures, facials, whatever. Are there some special challenges that we're not thinking about?
No, I think that face masks were great in the spa. Anything, you're going to get flashed. I was on an SAB call earlier with one of the laser companies, and the question came up is, what about ablative procedures in the plume? Is this virus in the plume? The answer is we don't know.
Very good point.
We don't know. We just don't know
Very
that.
good
So
point.
we were talking about suction. Matt Avram was on there talking about that, and we're just about suction and things. That's the one thing that we're scared of. We don't know. But hydrofacials. I mean, she should wear a mask anyway, and wear some kind of covering. We always wear eye protection in the OR. I mean, this is nothing different than we've been doing for our whole careers. Just be careful and universal precautions.
I think that's such a great point that you bring up about plume, because I thought of that. Ed Williams, thoughts on laser procedures, CO2 procedures, really any of the procedures create a lot of plume.
I don't know, Randy. It kind of scares me. But we don't microneedling. We do a lot of. We don't do as much of the CO2 laser. Once a quarter or something. But I really haven't thought of that. I thought of a couple little comments too, though. The little things we're doing. One of the things we're doing is, as we come back, things are going to be a slower pace. We're a little overstaffed. We're having our nurses. We're going to bring another service in to constantly be wiping, doorknobs and counter surface. We're having our, nurses are going to constantly, if, have a minute, they go over, they start just make the circuit around the office. Mm-hmm. One of the other things we're getting is these HEPA. In the spot of regular practice, HEPA filters, and I think the patients will feel more comfortable seeing that. And one of the other things I read somewhere, even just if you crack the windows a half inch, you're going to get a lot more air exchange through your facility. I don't know that it makes a difference, but if we know this stuff is aerosolized, I did. I wanted to ask if anyone has come up with reliable source of testing other than the hospitals. No, we're struggling with it. We've been.
I'm not sure that it's such a thing as reliable testing. I think we're seeing a new virus. A lot of tests were released, and most of them we didn't have the time to study these tests like we normally do to see how effective they are. So I think we're guessing at a lot of it right now. I know. From the people in New York where the largest number of infections are, there are a number of different tests that are being used. And I'm just not sure that we're going to find that the tests that we have today are going to be the final answer. I think we're still trying to find that right test, and the FDA just really hasn't had time to scrutinize this stuff. They just wanted to get it out there and satisfy the public that they're trying to do something. It's a tough issue. We've never seen this virus before, and it is a tough issue. I want to talk just a little. Yeah, go ahead.
You made a really good point. They tested 7,000 random patients in upstate New York, and over 15% were positive. So what does that mean? When you look at the number of deaths in the air, it's like 0.003%. But if you're that one, so that's what scares the hell out of us, right? The unpredictability of this whole thing.
Yeah, and it could be any age. You hear about, tragically, some young people passing away from this disease. It's not with no comorbidity, and you wonder why. So one of the things that before I turn it over to questions, we're going to talk about the surgical aspect of things. We're actually starting with the smaller procedures for a lot of reasons. We have a limited supply of something like propofol, and we use IV anesthesia for every patient. Propofol is in short supply, and it'll probably remain in short supply because that's how people they've been kept on that are on ventilators. And my guess is that maybe even the federal government is securing this drug for a second wave if it were to be necessary. I think it's going to be hard. I think supply chain is going to be very tough. For a number of different reasons. So we're actually starting by trying to do some of the cases where maybe we only need one vial of propofol, and we're trying to do, instead of the cases where we need 4 to 6 of them, we're trying to get those completed because we've got a lot of backlog. And then we're doing that as the first wave. And then the second wave, we're getting into a second wave of procedures. We're studying the hospital where we don't typically do many of our cases and haven't in the past, but we may have to do it in the future if we don't have the proper supply chain and drugs. So we're just making sure that we don't waste anything going forward. The testing is an issue. We talked about family members, but I want to ask Alex Tiersch a question about consents. And I think this is going to be one of the most important things that maybe we discussed tonight. It is to me, I've been on a malpractice insurance company board of directors before. I try to look at everything in a medical legal light. And I think it's kept me out of trouble for my many years in practice. I saw a permit or a consent today from the American Society of Plastic Surgery, and I forwarded it over to Morgan to take a look at it and to begin incorporating kind of a COVID consent into all of our operative consents, because there is some anecdotal evidence that some of the larger procedures can decrease your immune response to viruses and bacterial infections. And I don't know if it's cause and effect on the type of procedure, but there's certainly some evidence in the literature of that. And Alex, is that something that we need to talk to our patients about before we do a procedure? What if they were to get an active COVID infection from a family member 3 or 4 days after surgery? We have a responsibility, I would assume, to continue postoperative care, yet now we have a staff that would be exposed to that. And of course, people in the hospitals taking care of COVID patients are exposed to all of that. And God bless all of them, and a tip of the hat to all of our colleagues, by the way, who have been on the front lines. We can't thank them enough, and the nurses and the PAs and the respiratory techs. But Alex Tears, tell me a little bit about where the liability is for doing surgical cases in a COVID world.
Yeah, I mean, unfortunately, it's there. We've drafted a consent. I've seen probably a dozen different consents, different versions of COVID consents that have come through, saying everything, from you agree to accept the risk that this is possible. We've done everything that we can, but even if saying things like even if you've been tested, it could be considered a false negative test. I think it's a good idea to have that consent in place and to have that conversation with the patients, because if nothing else, you're covering yourself, you're putting it in writing, and as Mara said, if it's not in writing, it doesn't exist. So I think it's a good idea to put as much as you possibly can in writing in a consent form, but there's potential risk there, because we haven't seen the beginning of what these malpractice cases are going to look like. And, just reading some of the basic cases that have come out on some of these class action suits that are already being filed, it's inevitable that we're going to get wrapped up in these. So the consent form is key, and it's necessary both, preoperatively and then continuing that postoperatively. You also have duties under the Medical Practice Act in your particular state, standard of care, where you have to be following up, and you can't simply dump a patient, obviously, if they become positive. So you're absolutely right. You have to continue on with that. And I think that's something that perhaps your employees need to hear as well when it comes to consents for your employees and coming back, that they have to understand that this is it's a possible risk, and there's really no way to mitigate the risk 100%. I think one thing that's important to give your patients the option to is after you've discussed these consents, and this is required anyway by law, but make sure they understand that they have the opportunity to reschedule if they're not feeling safe, if they're not feeling comfortable at any point, because
that's a really good point.
And follow through with that. And I think we all have to be a little bit more lenient when it comes to things like offering refunds, whether it's patient holds or things like that. You've got to be careful, because there's a significant PR aspect here. I can only imagine, Randy, if someone were to get caught up in a matter where they've used all of their potential safety measures, someone still gets sick, and then they find some of these releases that maybe were signed or weren't signed. It's going to be an absolute mess from a PR perspective. I would tread with caution. I know everyone wants to open up. We have to open up in order to stay in business, but I would proceed conservatively. Take baby steps. The longer that it takes for us to get better testing, more accurate testing, quicker testing. That's a good thing. So there's no reason for us to rush back into this right away just because you can. Like, it's important to really take your time and be conservative with this. That's my advice.
Some great words of wisdom. I do have a question that's already been proposed to us, which is an interesting question, and I'm gonna start with I'm gonna go to Mara with this question. It says the College of Surgeons and AHA and AORN all say we should wait for 14 days of declining cases wherever we are before resuming elective cases. Is this even realistic with increased testing? Because as we test more, we're probably going to see more cases. So how do we balance that?
It is I bounce back and I come back to even what Alex said. I think because we're both in situations where we are working with practices across the country, and we have several clients that after having conversations, they have flat out said, look, I'm not comfortable opening back up. I know that my state says I can open back up, but I personally am not comfortable with that yet. And I think that we have to understand that this is going to take a long time for everybody to get back to a different version of normal. It is not going to be like it was 2.5 months ago. I think those times are over. And so with more testing, we will, like we're talking about, we will see more cases. And therefore, I think we've all talked too about this second wave that could very well be coming. And so when we are planning on getting back to work now, I think what everybody needs to do is also plan on what happens as we see a second wave. And so putting all of the processes and protocols of what happens for another shutdown and what happens for another open up. But, I think it's a way of answering the question that I think, we're going to have to see how legislature is going to continue to change. I
can't even imagine a second wave, but yes, it is something that's out there, and let's just say a prayer that somehow we avoid it. I have another question. What is the best resource to check on what are the regulations for aesthetic practices? I'm going to go to Morgan on that one because you've looked at a lot of these. What are the resources that have helped you the most in helping Waldman-Schantz-Turner Plastic Surgery come up with ways of creating protocols and guidelines?
Well, as I mentioned before, I think they all have the same thing in mind. But I would guess, ASPS, our accreditation body, gearing up to, reopen your OR if you haven't already been, practicing like a lot of the doctors on the panel have. And your government, our governor has been extremely, and he's kind of known for that now on the national news for being very, very conservative. So Kentucky is being mandated, very, very, cautiously. So between all of those on top of, I came across a really interesting article that one of our injectable reps, Dr. Waldman, you forwarded, our Galderma rep sent over something that they had put together. I think it's we're all in this together, and everybody is going off of credible sources, but also kind of getting ideas from other people, and going off of that. So I don't know if that answered your question, but
so I'll help answer. That's an excellent description of what we've done. But the College of Surgeons has a really good for this questionnaire. The College of Surgeons has some really good guidelines. As we said, the Aesthetic Authority has posted some protocols, and the American Society of Aesthetic Plastic Surgery, the American Society of Plastic Surgery. I would assume, Susan, Dr. Winkle, that the AAD has posted some things that are specific to dermatologists. You want to address that?
Yeah, both the ASDS, American Society of Dermatologic Surgeons, and the AAD have both been really supportive. I will say the whole spectrum of the way, even from helping support us financially and giving suggestions on how to navigate getting PPP loans. The Medicare, I just learned today from our academy that Medicare gave us a first wave of infusion of funds. We didn't even ask for it. all of a sudden in your account just showed up the money. If you accepted Medicare assignment, then you got, I'm not even sure how they calculated it. I just ended up with this chunk of money in my account. And now today they told us there's a second wave coming. This time you actually have to apply for it. But those are the kinds of things that our societies have really been amazingly helpful, I think, in really keeping us in tune with where we need to look, what kind of support we need. I think that part of their challenge, as we alluded to, is the fact that there's so much state variability, and these are national organizations. So we've also found that our local Florida chapter of the ASDS has been helpful in giving us, specific guidelines to Florida.
Well, I know that that's some really good guidelines have come out of each of the states, and I think that we're following Kentucky guidelines first, and then everyone else's guidelines, following that. Talking about the procedures, Dr. Posner, that you're doing, are you going to just kind of open up and do all procedures at the same time, or do you have some, I'm sure you have a lot of backlog surgery like we do. Are you going to adopt the approach that we did, or are you kind of just trying to randomize it? What are your concerns with who you're operating on, and are there some cases that that you've got scheduled that you're a little bit more wary about than others?
I'm actually not prioritizing anybody. What I'm really asking some of the patients is some of them have to get back to work sooner than others. So those of them have jobs with when they're going back. I'm trying to prioritize them. But other than that, I mean, look, we do general anesthesia as well as TIVO. So, I mean, if you're doing IV anesthesia and you're short of drugs, we do general anesthesia cases. We have a backlog of cases. We're going to just bring them in and do them, but just probably pretty much try to go back to normal on my surgical days. So I don't really think I'm going to see a difference in what I do or how I treat them, other than some preoperative testing and our usual universal precautions during the cases. The main thing is, as I said earlier, on our patient days and clinic days, different story. But on the surgical days, we're going to do everything we have scheduled. But I only do 3 or 4 different cases anyway. I mean, it's faces and revision breast. I mean, that's all I do, and some lipo.
Well, let me go over to Ed Williams then. Any particular fear with rhinoplasty, Ed? I know you alluded to that before.
Yeah, I mean, it concerns me. It's a big part of my practice. But fortunately, maybe the last, 8 or 10 years, I've pretty much switched over to general, and I feel a little bit more comfortable, doing general on a rhinoplasty. Same thing with a, MAC and a facelift. I'd much rather do general, which is what we prefer to do. I think it'll also cut down on, using propofol, but I do feel more comfortable with a tube in there than the patient breathing all around the room. I initially was holding off on rhinoplasty the first month. I think we had that conversation, and I said, well, kind of like the universal precautions thing, we're doing this under general, and I do plan on doing them. That's what I'm doing. I don't,
I'm going to go over to Ivan Wayne. Some people have talked about ASPS has guidelines for 7 days of isolation after surgery of a patient, being relatively isolated from family contacts, and some people have talked about from the point of testing, whenever that is, that the patient should be isolated, prior to surgery, so that there's no chance of getting infected between testing and surgery. Both pre-op and post-op. Can you talk a little bit about your thoughts on having the patients stay relatively, away from family and friends and that type of thing?
Sure. And I'm glad you brought that up, because that is truly my biggest fear going forward. I have low fear of myself getting infected, but think about, the more senior facelift patient that, if you look at the people that do the worst with COVID-19 are people that are of advanced age and have comorbidities. I don't tend to do facelifts on patients with comorbidities, but I do have a lot of patients that are over the age of 65 that I do those procedures on. My worst fear is in the immediate postoperative period. Their defenses are down. They've had general anesthesia. Their pulmonary function might be a little impaired, and they get COVID-19, end up on the unit, and who knows what might happen. So I think that's an excellent idea, and that's going to be part of my consent process with really any procedure, is social isolation before, and we'll test you before, and then social isolation that first week after. I think that's a really good idea. I think the patients will be pretty compliant. I mean, they know how to do it. They've had 5 weeks of practice here.
Well, that's very true, for sure. I'm just going to go around the panel and give you a chance to say, speak to anything that perhaps I haven't brought up, and we're still fielding some questions, but I'm just going to start with Ed Williams again to try to summarize where we've been and where you think we are, and perhaps where we're going to be a month or two from now.
Boy, I don't know, Randy. I don't, I think we all went through our first phase of total disbelief, right? I mean, if you think about where we are now in society and walking around with masks, I almost can't even believe it. There are a lot of things that are going to change. The way, there are a lot of things that are going to change. I don't really have a lot to add. I think a lot has been covered tonight. The new normal, slow down, take a deep breath. Even when you're seeing patients, it's funny because I never realized how much I missed it, and missed my team getting back there. So I don't know. I don't know where things are going to go. I mean, I'm the eternal optimist. So we might hear people talking about the second wave, and I mean, I don't think about it. As I mentioned earlier, all we need is one disaster, and if it's you or someone you care about or one of your team members, it's going to be awful. So at least if we do everything we possibly can, and like I said, I don't think we can over test, even if these tests aren't 100% reliable. And I'm talking about primarily surgery and more of the more of the bigger procedures. But at least we know we've done our very best. That's really all I have to add.
Alex, Tirsch, same question to you. Your observations after listening to, a bunch of us kind of talk about how we're doing things and where you think the future lies.
I think what Edwin just said was spot on. I agree with it. It's impossible. I was just having a conversation with some lawyers today. It's impossible to predict where we're going to be, right? We just have no clue. It could go in so many different directions. And I think you just, one thing I wanted to comment on is the state level law is probably the most important thing you need to look at. The guidance from the colleges and all that is great, but what is your state mandating as far as what you can purchase from a PPP perspective? What types of things you can do. I mean, that's where you have to start. I think it's going to take some time to get back to normal. There's a long way to go just in figuring out where this is going to be as far as testing goes. So I would everyone needs to I agree, to take a deep breath. It's probably going to take a little bit longer than we think. And if you set your expectations there, and do what you can, have the right consents, have the right protocol, practice those protocols, practice, be diligent about that. That's really all we can do, because we're in uncharted territory right now. So I listen to lawyers talk all day, and I kind of shake my head when they give out this, steadfast advice. It's like, how do we know? We just don't know at this point. We've got to do the best we can under the circumstances.
Susan Winkle, I'm going to give you a couple questions first, and then I'm going to let you do that same kind of sort of roundup. But it said, Dr. Winkle mentioned TheraMask. What is the benefits of it in comparison to surgical masks, and where do you get these TheraMasks?
There's a company, NewFlex, I think it's called. Hydrofacial's also selling them. So if you do hydrofacials, you can reach out to that company because they have them.
Hydrofacials, okay.
Yeah, and the advantage is, from what I've read about them, is they're impregnated with copper. And that copper actually kills bacteria and viruses if they land on the exterior of a mask. Because we know a regular surgical mask protects the around you from you giving it to someone, but doesn't protect you from getting it, right? And so this mask would, like an N95, appear to protect you from getting the virus from someone else.
All right, another quick question.
More comfortable.
Have you found the comfort is really key there, because the N95 you wear for maybe an hour at a time, and then you get kind of miserable. But have you found a device? This is a question. Have you found a device to disinfect the area air, such as UVC devices or plasma air disinfectants? And on top of that, one of my friends sent me something today about something that releases something into the air that helps disinfect surfaces. And I just started looking into that. I'm not even really sure what that's about or whether it's been proven in studies to really be effective. Susan, you're good at that kind of thing. What do you think? Does that make it?
Just so happens I researched it today. I got tuned into looking at what the air quality is in the office. Not only, so if it's particles that are falling on the surfaces, how much do we need to improve our air quality? So I looked up IQ Air is one device. It's actually FDA approved. And so there are a number of these devices for filtering air in the office as one approach. But then I called the infectious disease doctor, and I spoke with our doctor, and he didn't have much faith in them because of the viral particle size. The coronavirus is 0.3 microns, and he just doesn't think they're going to filter that effectively, even though in their advertising they actually say that. So he's very skeptical about that. And then there's a concept of having the office fogged. Now, there is a company, actually, it's in Sarasota, and they have come up with a way to fog offices, private planes, different things. And so I think the future may be that we're going to need to develop or see that kind of agent where we can actually come in, and when they clean our office, as Jason says, they're cleaning everything. In my office, you could eat off the floor right now because I haven't furloughed anyone, and they're all been in there cleaning. Man, we have cleaned every cupboard that 27 years hadn't even been looked at. And so I think that may be an addition to our cleaning going forward that may potentially also help protect us.
I have another question. Can we get a copy of a consent form to use pre-op? If anyone out there, you can contact Eliza Cabana at the Aesthetic Authority, and we'll forward our consent form that we're going to create or that we've gotten together to her, and she can distribute to anybody that wants to see that consent form. Susan, anything else, and just kind of what you've heard tonight that just you feel like we haven't covered or that we should talk about, or, you know, concerns going forward?
I really think it's been an excellent session. One thing that comes to my mind is we probably at some point need to all reach out to our international colleagues, for friends of ours who are maybe in places where they are further ahead, further down the road. Wilson Ho, for instance, in China. I mean, we have some very, very experienced surgeons, dermatologists globally who I think may also give us some input and guidance. And I would think going forward, that would be another good input for us.
I got a question, and I hope this wouldn't be the case, but this question is, what are practices doing to prepare for potential IRS audits regarding the PPP loans? Let's hope that we're doing the right thing and that we've done it right. And if we don't use all the loan, that we give it back, or we use it at 1%.
I'd like to add something to that, Randy. One thing I'm doing, because I did just get my PPP loan yesterday, which I was ecstatic about. And so I'm opening up a separate account, banking account, just for the PPP one. And I'm opening a separate one just for the Medicare money that we received, so that it's very easy to track where that, so it's not intermingled with any of your other financial accounts. And it's very clear and easy to follow where that money went.
Mara Shore, this is a question for you. Which platforms have you found to be the best ones for virtual consults? Zoom, FaceTime, Skype, Doxy? Pros and cons of these, or any feelings on how to up your game with virtual consultations? I get bombed with these things, probably 5 to 7 of these a day. So, thoughts?
Good question, Brett. Or you get so. One thing that I think what we need to make sure, FaceTime, I'm still very sketchy about just using FaceTime because it wasn't set up as a compliant platform. We know that Zoom has had some issues as far as, the safety there. I know Skype for Business. I've seen the HIPAA compliant paperwork. Doxy was set up. Doxy.me was actually set up for this purpose. So as far as that is concerned, I would also check with your EMR system because whoever, for people out there, I encourage you check with your EMR because right now the EMRs, a lot of them are integrating this. And so it's going to be a lot more seamless. Plus, that it's HIPAA compliant. Different ones I know, Nextech has done some integration. Simplast has it. So I think start with what your EMR has as well. I think that's a great place to start.
That's a question for Dr. Williams. When testing pre-op, Dr. Williams, is it done? I mean, are you planning on having it done? Who's performing the test? Your surgical center, your office? Do you send them to the hospital? Who's actually getting the swab? If that's what you're using, or the sample. And if so, who have you contracted with to run the test? Some of the hospitals, it says that this person operates have said 2 negative PCR tests prior to any nasal procedures, but no guidance as to where these were to be done. That's a confusing thing to me too. Are you as confused as we are about the appropriate protocol and who's getting the test and how to prepare that person to take tests if they've never done it?
Yeah. No, and I think it's one of the reasons that there are some false negatives because if they're not being done correctly, so we have one of our LabCorp locally here is just announced today they'll be doing them, but we don't know is that going to be available to anyone, any physician's office. For example, the Albany Medical Center, they're opening up their elective cases very soon, and they have a protocol, but they have a testing right there on site. Initially looking at the MIG serology testing, that's easy enough to do right in the office. But there are we had contemplated if the Abbott machine was available, the one that like people use for influenza and other types of things, to have that. That's a very it's $5,000 or $6,000. You have to get a CLIA number. But I don't have the answer to that, Randy. I mean, our goal is we want to try to test everyone prior to surgery. Whether we do 2 tests or 1. I mean, initially we're going to start out with 1 and also do serology testing. But our problem is we're having a hard time locating the tests. We're not having a problem with PPP. We're just having a hard time getting tests. It's interesting when you look at American College of Surgeons, ASPS or ASAPs, nobody mandates, including most of the states, don't mandate testing. So I think they all realize it's a bag of worms, and that's why I asked that question. Does anyone know where there's some type of reasonable? I think
actually, Ed, I think our state does. Am I wrong about that, Morgan? Or is it mandated by the state of Kentucky right now for surgery?
It's like Dr. Williams said, I think it's all recommended. And it's recommended by our Quad ASF, which is who is our accreditation body. So, that then you get into the legality portion of it, if you don't test your patient and then, so that's what's hard. You're kind of treading water. So you want to make it your mandate to test everybody.
Right. I mean, I think
I think that's a great point.
I think the serology tests are going to be easier, but again, there's a lot of variability and the active tests.
I think the serology test is really inaccurate right now. At least what I'm hearing from colleagues in New York City that it's just not, because the one thing with serology too, it's 6 to 8 weeks afterwards, so it's a little difficult to determine when somebody might have been infected. That's a bit of a problem. So I'm going to go over a couple last words that from those of you. Ivan, Wayne, your thoughts on all of this that we've talked about tonight. And by the way, Ed, you bring up one point before Ivan speaks. maybe our next session will just be on testing. I mean, the complexity of testing is really so unknown to all of us that maybe that's kind of next horizon for one of these discussion sites on, how do we cut through all of this, and how do we understand that we're not people that are used to infectious disease and testing and all of that. This is so foreign to all of us. We're used to CBCs and, various panels, but we're not used to infectious disease types of testing. And now it's being thrown at us, and we have to understand what all these different tests do. So, Dr. Posner, I know you've been listening intently and trying to, trying to figure out what the future is. But, really, where are we going with all this?
Honestly, I have no idea. I don't think any of us have any idea. But, can I twist it around a little bit, Randy?
Absolutely. I love when you twist it around.
Let me throw a little twist. We know clearly the one industry that's devastated is going to be the travel industry. No one in their right mind is going to be traveling this summer. I'm telling you, mark my words, this is going to be a very busy summer for surgeons because everyone's going to be stuck home. They want stuff done. Last summer, the economy was great, and my July sucked because everybody with 2 cents was in Europe or somewhere else. Everyone was out of town. Our town was a ghost town in July. I think this summer is going to be very busy for all of us. So I hope we get this stuff straightened out by then. How's that?
Yeah, I hope you're right, and I pray you're right. I mean, I think all of us are looking forward to that. Ivan, kind of final thoughts on all of this stuff.
So just to follow up on what you talked with Ed Williams, I'm doing the PCR test myself. It's a nasal swab. It takes 20 seconds, really easy to do. I've done it a couple of times. Patients feel great about not having to go to a hospital or an ER. I think Ed Williams also, the point about going slow, just let's start really slow. I think there'll be a second wave. I hope not, but let's be ready. I mean, the worst thing would be to be all ramped up again and then to get immediately shut down because there's a whole bunch of positive people. I think it's coming. Oklahoma had its peak March 24th, about 2 weeks after we shut down, and we've been dropping, and now we're opening up Friday, wide open, everything, restaurants. I'm scared. It's going to happen. We'll see. We might be a model state. I hope not, but I'm prepared for it. So go slow. There's no race here. Let's really take it easy.
I think that's super advice. I'm going to let the audience know that the Aesthetic Authority's email, by the way, if you want to contact, is aesthetic, A-U-T-H. So aesthetic, A-U-T-H at gmail.com. Aesthetic, A-U-T-H at gmail.com. If you have any questions for any of the presenters, rather than give out, we could give out individual email addresses, but we'd have to put it on the screen. Just contact the Aesthetic Auth, A-U-T-H, at Gmail, and they'll distribute questions appropriately. You can sign up for the e-newsletter for more information from the Aesthetic Authority. We post some things on there. And that this actual webinar was recorded and will be available on the Aesthetic Authority in the next couple of days if you want to refer back to it, listen back to it, or refer somebody else to it that couldn't be online with us tonight. Aesthetic Authority will publish answers to many of the questions, by the way, that we weren't able to get to tonight. We actually had another 100 questions to get to, but with time limitations and the hours getting further along, then we'll try to defer those questions, and they'll be available on the website. I'd like to thank all of our panel members for participating tonight. I hope it was informative to everyone out there. A special appreciation to everyone taking their evening and trying to learn a little bit more about what's coming up. I hope it was valuable. We'll probably come on with another one of these roundtable discussions in the next 2 or 3 weeks when issues arise and we really have something, I think, important to talk about. One more time, just open it up to anybody on our panel that wants to make a final statement or anything that that really you feel is germane to this discussion tonight?
I just wanted to say about the fogging system. It's by a company called, I didn't mention that, I'm sorry, Durasan, Durisan. I have no interest or I have no disclosure, but it is a company that has a sanitizer, and it has as well that they can come in and actually just fog a whole place if we go in that direction. Just a thought.
Very good. Mara, anything final? I don't know that I called on you at the end, but any final statement about just helping us try to get back to normal as a consultant?
Yeah, absolutely. I think that the most important thing and what we are really focusing on is communication with our clients right now. Putting a plan into place for what does the next 1 week, 2 weeks, 1 month, 2 months. I think that to look any further than maybe 2 months ahead right now is a little uncertain. But what I would say is, put in place a plan for your employees, communication plans and protocols and meeting structures, plans as well. And then have regular meetings with, and we're encouraging all of our clients to do this as well, regular meetings with your accountant. If you have a consultant, regular meetings with your consultant. We're doing that with all of our clients. Regular meetings with your lawyers. I know we work really closely with different healthcare attorneys. I know we work closely with Verdadado, with which Alex is a partner, and they're doing that with their clients as well. Hopping on the phone, if ever anything you don't understand about terminology and the legalese, really have those conversations, because you don't want to be caught with your pants down there. And
so one more person, and then I'm gonna call it an evening. Alex Tiersch, what's your biggest concern for all of us going forward? Where do you, when you look at this globally, what should be our biggest concern? And I'm sure you're going to say safety of the people coming into practice, and we all agree with that. But if you were looking into a crystal ball, we're going to look back at this and we're going to say what?
That's a loaded question, Randy. I will tell you, there's so much that makes me nervous about this. Honestly, just hearing all of the different plans that people are putting together with testing. I mean, there's a million different things that could happen. I honestly, there's like in thinking about giving somebody a test beforehand, before the surgery, but then they somehow contract the virus in between that test and the surgery happens, then like you've got a whole nother ball of wax right there. I mean, there is literally an endless tree of things that we as lawyers are thinking about right now. And so what I can say is that because none of us have been through this before and it's a totally novel situation, we all just need to do our absolute best and think of kind of on the humanity side of things, like we're all in this together. So if you don't need to do a filler procedure, then don't do a filler procedure. Like just take it slow and let's be conservative with this, because it's going to take time to get through this. So that's probably not the best answer that you want to hear, but we're all lawyers are dealing with this too. And this is all a novel thing for us.
Well, I'm going to tell everybody I'm going to end on an optimistic note and say that maybe we'll convene a panel in the future where we just talk about medical legal aspects of the COVID crisis, Alex. But I'm going to add on a positive note. There is some help for us. As I said, Ivan Wayne has the Aesthetic Practice Think Tank, which is a great place to collaborate with colleagues. And I think 124 people actually participate in that site. It's very active, and I've gotten a lot of great information. It started early on, and we started talking about this, and then we created a site. It was my idea to create a site on the Aesthetic Authority called The Coronavirus in the Private Practice. And we started that 4 or 5 weeks ago. And that's where I first learned about PPP loans and forgiveness and a lot of the issues about patient safety and testing, and there are about 100 people that are actively participating in that site. So it's another good reference site, and both of those are on Facebook. There are a ton of sites. Our societies have some good sites out there, and if they don't, they should. And I just think that we're all in this thing together. As Alex Tier, we're all in this thing together, 100%. And I've learned so much from colleagues over the last few weeks, and that's what's been really a nice part of this, is that we've had a lot more time to communicate with colleagues and collectively in this environment. The same thing with your staff. I would tell each of you to listen to your staff. They're our lifeline in this particular situation. We can't exist without them. Be sensitive to their fears, be sensitive to their needs, and listen to them, because they understand as much as we do of what's going on out there in people's minds. I think that what I heard tonight across the board was that we walk slowly, as I've always said, 0 to 60. But I think at this point, I'm happy with 25 to 30, and maybe we can get 60 at the end of the summer. Hopefully, without a second wave, we can certainly get there in the fall. And I think it's a little bit of baby steps, because I think what I told my staff earlier today, we're in this for the long run, not the short run. And we want to make sure that we're in good shape at the end of the year, not next week as much. So if I was giving advice to anybody, is the other thing that I always say is do the right thing. Whatever that is, do the right thing. And I think if we do that, and we interact with our colleagues, and we draw on each other for advice, we interact with our societies, we interact with our publications, our consultants, we work with our anesthesia people, make sure that they feel good about things, then we'll all come out of this, and it'll be fine at the end of the day. There is, as I said, there is light at the end of the tunnel, at least a lot more than there was 6 weeks ago. So I appreciate everybody coming. I hope it was informative, and we'll come back and do this another night. Thanks, everybody.